topic for discussion is jaundice, which is also known as icterus. This jaundice is usually characterized by yellowish discoloration of skin, sclera and mucosa. Jaundice is usually caused because of excessive production of bilirubin or excess bilirubin within the circulation and accumulation of this bilirubin in the body tissues. Usually, if at all the bilirubin is above its normal standards, that is more than 2.5 milligram per deciliter or 40 micromoles per liter, then it is considered to be jaundice. Usually, bilirubin metabolism is as follows. Liver is one of the main organ that will actually help, is related to the bilirubin metabolism. Heme, because of the catabolism of heme or breakdown of heme, about 250 to 300 milligrams of bilirubin is produced daily. This bilirubin which is produced because of the catabolism of heme within the blood is usually unconjugated. That is, it does not mix with, it doesn't bound or it is not water soluble. Hence, it bonds with the albumin material. Now, this unconjugated bilirubin is absorbed by the hepatocytes of the liver. Once this is taken into the liver with the help of an enzyme called UDP glucuronyl transferase, this unconjugated bilirubin converts into conjugated bilirubin, which is now water soluble. Now this conjugated bilirubin is of two forms, that is bilirubin monoglucuronide or bilirubin diglucuramide. These two forms are usually water soluble. With the help of the now this two conjugated bilirubin material is now excreted into the bile and it is transferred via the bile ducts into the duodenal lumen. Within the duodenal lumen, what happens is the colonic bacteria which is present will actually start the metabolism of this conjugated bilirubin. Now this conjugated bilirubin will, with the help of the glucuronic acid that is removed by the bacteria, gets converted into stercobilinogen. This stercobilinogen is further oxidized and it is converts into stercobilin, which is excreted into the feces, and that actually gives a color to the feces. It is about brown color. Now, some of this material of stercobilinogen, about 4 milligram per day, is reabsorbed by the lumen, and this is excreted via urine, and this is called as urobilinogen, which is again further oxidized into urobilin. Now what happens is, whenever in this whole process of metabolism of this bilirubin, if at all there is the proper metabolism of this bilirubin is hampered because of alpha glucuronyl transferase, then there will be inherited hyperbilirubinemia, which is a condition that leads into jaundice. Another condition where if at all there is biliary obstruction, that is the conjugated bilirubin, which is actually has to be in the proper normal metabolism, which actually has to be transferred via this bile into the duodenal lumen, is obstructed, it will lead into obstructive jaundice. So this is the metabolism of bilirubin and the causation of jaundice if there is an impaired metabolism of bilirubin. Coming to the etiopathogenesis, this jaundice can be caused because of various reasons. First is increased production of bilirubin. This increased production of bilirubin can be because of hemolytic condition, where more amount of heme is produced, this heme is catabolized further and more amount of bilirubin is produced. Thus this bilirubin metabolism again follows, resulting in increased bilirubin within the blood or deposition of bilirubin into the body tissues, resulting in jaundice. Next other important cause is obstruction of biliary tree. If there is any obstruction for this transfer of the conjugated bilirubin into the duodenal lumen, can result in jaundice again. Other conditions include impaired excretion, which is nothing but congenital non-hemolytic hyperbilirubinemia, hepatocellular jaundice and cholecystitis. Hemolytic jaundice. This is due to hemolytic anemias, like for example, spherocytosis or sickle cell anemia. In this condition, what happens is there will be premature breakdown of RBCs, resulting in excess of heme production. Further, this heme gets catabolized, giving rise to excess amount of bilirubin. Usually, the mild hyperbilirubinemia is seen in these cases, except for infants and patients with liver diseases. If the underlying cause of this hemolytic diseases is treated, then jaundice can also be treated. Other causes of hemolytic anemias can be any infection-induced hemolysis, high temperature-induced hemolysis. In these conditions also, there can be mild increase in bilirubin, resulting in hyperbilirubinemia and thus resulting in jaundice. In these conditions of hemolytic induced hemolytic anemias induced jaundice, there will be discoloration of eye, that is yellowish discoloration of the sclera, mucosa, skin, etc. But however, as the bilirubinemia itself is mild, these symptoms also are milder in manifestation. This can be due the breakdown of the RBC can be due to inherent abnormalities of the cells, for example spherocytosis, or it can be because of any autoimmune conditions, or it can be because of certain drugs and poisonous agents like those that are present within the fava beans, etc. Even in G6PD deficiency also there can be breakdown of RBCs. Coming to the clinical features, normally as I already told, bilirubinemia is little milder in the hemolytic anemia cases. The color of the stools is usually normal to dark colored stools and urine. Patient is paler and there will be splenomegaly because of excessive destruction of RBC. Next is various investigations that help in identifying this hemolytic anemia is complete blood picture and smear. In the peripheral smears we can usually see different shapes of the cells also. There can be anisocytosis also, or spherical shaped of the RBC, which is nothing but spherocytosis, etc. And there will be decreased serum haptoglobins and there is increased serum bilirubin, that is more than, if it is more than 6 mg per deciliter, and liver function test also will help in identifying this. One important thing that has to be remembered is that in hemolytic anemias induced jaundice, usually liver function tests are normal because there is nothing to do with the liver in this pathology. It is because of the excessive heme production. Hence the liver function tests are usually normal in these cases, unless if there is a secondary or if there is a associated hepatic disease, for example like in children or chronic alcohol consuming patients, etc. Coming to congenital non-hemolytic hyperbilirubinemia, as we discussed in the bilirubin metabolism, if at all the alpha glucuronyl transferase enzyme, UDP alpha glucuronyl transferase enzyme doesn't function properly in conversion of this unconjugated bilirubin to conjugated bilirubin, then it can result in congenital non-hemolytic hyperbilirubinemia. Various syndromes that are associated with this include Gilbert syndrome, Dubin-Johnson syndrome and Rotas syndrome. Coming to obstructive jaundice. As the name itself indicates, there is some obstruction for the flow of this bilirubin, that is either obstruction within the within the liver or obstruction outside the liver. Hence the reasons can be either intrahepatic or extrahepatic, and it is because of it can be either because of partial or complete obstruction of the bile flow also. Extrahepatic causes that usually are causing this jaundice include malignancies, where especially the tumors of pancreatic head. This tumors of pancreatic head can cause, it can actually compress the flow. It can compress the flow, thus there will be partial obstruction for the flow of the biles, which is actually hepatic. The liver will excrete this bilirubin into the bile, and this bile actually comes into the duodenal lumen. So there will be obstruction of this bile. Next is any gallstones. If there is any gallstones also, there will be obstruction. Cystic fibrosis, any infections or trauma or other extrahepatic causes that will result in jaundice. Coming to various intrahepatic causes, hepatitis condition can be either viral hepatic condition or alcoholic hepatitis or cirrhotic conditions, and primary biliary cirrhosis, any drugs and alcohol consumption, chronic alcohol uses, and lymphomas or any other metastatic carcinomas within the liver are some of the few intrahepatic causes that can result in jaundice. Various clinical features of this obstructive jaundice include cholestasis or cholangitis. If at all it is cholangitis, that is inflammation is present, then it can result in fever, pain and liver abscess. There are again early features and late features that can be seen. Early features include dark urine, jaundice, pale stools and pruritus. And late manifestations will include malabsorption, steatorrhea, that is excretion of fat in the stools, weight loss, osteomalacia, and patients will also have severe bleeding tendency. This bleeding tendency is because they will have liver is compromised, and as we all know, some of the clotting factors, that is 1 to 4, are usually are produced from the liver, and as liver is compromised, patient will also exhibit various bleeding tendencies. This picture shows yellowish discoloration of the sclera, which is one of the pathognomic feature of jaundice. as the yellowish discoloration can be more seen in the bulbar conjunctiva. Next is, what are the investigations that help us in identifying jaundice because of obstructive, because the cause is obstruction. It includes history and clinical features. History should also include patient's habit history and also any previous hepatic incidences. Liver function test. Usually liver function test in this obstructive jaundice shows some abnormalities. There will be increased alkaline phosphatase levels and also GGTP. Ultrasound, endoscopic ultrasound and cholangiography will also be helpful, especially in identifying any gallstones. Coming to hepatocellular jaundice, it is usually a parenchymal liver disease, and it is other reasons for this hepatocellular jaundice includes alcoholic hepatitis, drug-induced hepatotoxicity, etc. There will be increase in both conjugated and unconjugated bilirubin levels. Coming to the clinical features, there will be jaundice, fever, malaise. Patient will also have anorexia, and the characteristic feature of spider angiomas, jaundice, ascites, gynecomastia can also be seen in this condition. Drug-induced hepatitis can also lead to jaundice. In this, what happens is it can be either idiosyncratic or a dose-dependent one. Most common drug that will actually is damaging to the liver is acetaminophen, that is the normal paracetamol. On taking overdoses, it can cause damage to the liver. Other drugs include phenytoin and sulfonamides. So how can we manage this jaundice? As I already told, jaundice is a condition which will be manifested because of any underlying diseases. It can be either intrahepatic or extrahepatic. It can be a genetical reason because of obstruction, etc. If these conditions are treated, then jaundice can be treated. So it can be treated by addressing the underlying condition. The topic for discussion is hepatitis. As the name itself says, it is inflammation of the liver. Hepatitis can be of two forms, which is acute inflammation and chronic inflammation. Acute inflammation is usually heals faster, whereas chronic inflammation, it can result in fibrosis and then further cirrhosis of the liver. Most common etiological factors for this cirrhosis of liver include viral, autoimmune and some other conditions. Viral hepatitis most commonly is hepatitis A, B, C, D, E viruses, Epstein-Barr viruses, cytomegalovirus and herpes simplex virus. When coming to autoimmune conditions, it can result in chronic autoimmune hepatitis and alcohol, drugs, etc. Wilson's disease is one other cause of this hepatitis of the liver. Coming to the types of hepatitis, can be classified as acute hepatitis and chronic hepatitis. In acute hepatitis, there will be damage to the hepatocytes. It is usually the pathognomic feature is there will be these damaged hepatocytes are swollen, granular, while the dead ones are usually shrunken. Other conditions like globulitis and rhabditis are some of the conditions of this acute hepatitis. In the acute hepatitis, there will be collapse of this reticulin framework. Then there will be bridging or subacute hepatic necrosis and further leading to massive necrosis. Whenever there is this massive necrosis, it can lead to acute hepatic failure. This is one of the fatal or potentially fatal condition in case of acute hepatitis. It can also result in cholestasis, where there will be obstruction of the bile or resulting in gallstones. There will be gallstones also seen in these cases. Then coming to chronic hepatitis condition, there will be inflammation of the portal tracts. In acute hepatitis, there is inflammation of the hepatocytes themselves, and in case of chronic hepatitis, there will be inflammation of these portal tracts. In chronic hepatitis, what happens is there will be interface hepatitis, which further continues into parenchymal damage. Later, it results in fibrosis, and further continuation or progression of this disease results in cirrhosis of the liver. Most common symptoms that are associated with this chronic hepatitis include patient will have fatigue, anorexia, they will have nausea, pain, upper abdominal pain or discomfort. In case of severe hepatitis, this will lead into acute liver failure because of the necrosis of the liver, and further it can also lead to encephalopathy or jaundice, and with patient will have increased prothrombin times. This is a picture which shows how the liver, the progression of the disease in this hepatitis condition happens. First it will have a fatty liver, later there will be liver fibrosis, and further it continues to cirrhosis. In fatty liver, what happens is there will be deposition of fatty substances which will cause enlargement of the liver. That is nothing but hepatomegaly. On further progression from this fatty liver, it changes to liver fibrosis, where there will be fibrotic changes happening within the liver. That is scar tissue formation, and more liver cell injury happens in this stage. That is nothing but liver fibrosis. It further continues into cirrhosis of the liver, where this scar tissue will make liver hard and it will be unable to work properly. That means it loses its resiliency and functionality of the liver will get hampered in this case. That is in cirrhosis of the liver. As I already told, the various causes or etiological factors for the hepatitis. One most common cause of hepatitis is viral hepatitis. Among this viral hepatitis, hepatitis A, B, C, D, E viruses are one of the most common causes. We might think this hepatitis A, B, C, D belong to the same family, but they are only named because these viruses will result in hepatitis, but these all 5 viruses do not belong to one single family. They belong to different family of viruses. Coming to hepatitis viruses A, B, C, D, E, other one is also present, that is non-A, non-B virus, non-C hepatitis viruses, and cytomegalovirus, Epstein-Barr virus, and herpes simplex virus. However, all these viruses have similar clinical manifestations, and most of the other viral induced hepatitis are usually asymptomatic or anicteric. Anicteric means they do not manifest jaundice in most of the cases. It is like a silent killer kind of a hepatitis. Most of them are asymptomatic or less symptomatic. Coming to hepatitis A virus, this hepatitis A virus transmission is through fecal oral route and it belongs to picornavirus group. It is highly infectious. It is most commonly seen in case of children. In areas where there is poor sanitation and contamination of food and water because of this virus can result in this hepatitis A induced hepatitis. That is, the transmission is through fecal-oral route. Next is hepatitis B. It is one of the major cause of causative virus among the all viruses that is present, resulting in hepatitis. It belongs to hepatnavirus, and the structure of this virus is it has a capsule and a core, and DNA is present with DNA polymerase. And there are multiple glycoproteins emanating from this outer capsule. These viruses are obtained from the host cell membrane itself. This hepatitis B virus, the main source of infection is man, and usually the host itself is also man. And various modes of transmission are present for this hepatitis B virus, and the predominant mode of transmission is through blood. That is either through blood transfusion or because of any organ transplantation, in case of any sexual intercourse, and in vertical transmission, that is directly from mother to child. In these cases also there will be transmission of this hepatitis B virus. It is highly infectious, and this virus it is known to be highly infectious, and the patient is also has that chance of infecting other people whenever the capsule and this virus is higher in number in the blood circulation. Coming to hepatitis C. Hepatitis C belongs to flavivirus. It is an RNA virus, whereas hepatitis B is a DNA virus. Hepatitis C is an RNA virus. It is also usually bloodborne. The pathogenesis or transmission is bloodborne transmission, and most commonly because of post-transfusion hepatitis and parenteral drug users. And this figure shows us the various routes of hepatitis C transmission, where about 60% of patients, in 60% of patients, the transmission is by injection drug use, that is drug abuse conditions, or using a syringe, which has been multiple use of syringe, that is not using disposable syringes, etc. And about 15% of patients it is because of unprotected sexual intercourse, and about 10% is because of transfusion, where the blood is not being screened for hepatitis viruses before transfusion for other person, and other conditions like hemodialysis in case of renal patients, renal disease patients, CKD patients, and in case of healthcare workers, and perinatal, that is vertical transmission. And about 10% of causes unknown why this hepatitis C related hepatitis disease is being found. Coming to hepatitis D virus, it is also an RNA virus and it needs HPV for its existence or spread. Hepatitis D virus usually does not exist as a separate entity. It associated with hepatitis B. As it is in combination, this will help for rapid progression and severity of the disease also will increase. This will lead to chronic hepatitis condition. Coming to hepatitis E, it is a RNA virus and mode of transmission is again fecal oral route. Here also, because of poor sanitation or contaminated food and water can result in transmission of this hepatitis E virus. It is most commonly waterborne hepatitis. The hepatitis that is caused because of hepatitis E is also called as waterborne hepatitis, and clinically it resembles HAV, that is hepatitis A virus. And in pregnant women, if at all she is infected by hepatitis E, there will be high risk for acute hepatic failure. Coming to the clinical features of this hepatitis, usually there will be prodromal symptoms which includes fever, malaise, nausea, myalgia, and before the occurrence of jaundice, that is before jaundice has been manifested, these prodromal symptoms can be seen in these patients. Next, patient will also have rigors. Various GI symptoms can be seen in case of hepatitis. These GI symptoms usually include anorexia, dysgeusia, that is bad taste, nausea and vomitings, and also patient will manifest with diarrhea. And other one pathognomic feature of this hepatitis is usually patient will have this upper abdominal pain and discomfort. Patient will also exhibit with hepatic tenderness because of hepatomegaly in these cases, and patient will also have cervical lymphadenopathy, splenomegaly and arthralgia when it involves bones. HPV is known to cause a pathognomic or particular manifestation, that is nothing but serum sickness syndrome. And in hepatomegaly conditions, whenever hepatomegaly is manifested, patients will also exhibit yellow sclera, dark urine and paler stools. Usually patients recover by 3 to 4 weeks of period of time, and if it is untreated, usually it prolongs for more than this stipulated time. So what are the investigations? How we will know the patient is suffering from hepatitis? Various investigations are: the primary investigation for hepatitis is liver function test. Here, as a liver is involved, various parameters of this liver function test can be altered. In that, patient may have increased plasma aminotransferase, about 400, more than 400 units per liter, and patient will also show increased alkaline phosphatase levels, which will be about more than 250 units per liter, and also there will be increased bilirubin. However, albumin may be normal in these conditions. And other investigations include patient's prothrombin time will be elevated. Why is the prothrombin time elevated? Because of the few of the clotting factors that has to be produced from the liver are compromised. And patient will also exhibit bilirubinemia and mild proteinuria. Other serological tests include serological test for the antibodies of this HIV virus. HAV, that is HIV, HBV and HEV. But however, for HCV, the serological tests are usually unreliable. Whereas virological tests are also available to know which type of this virus is causing this hepatitis. For hepatitis A, we have anti-HAV of IgM type that can be checked in blood. And for HBV, we can have HBs AG, which is nothing but the surface antigen. It will help in, it is actually a reliable marker for HPV infections, that is hepatitis B infection resulting in hepatitis. And then we have anti-HBs, which is this anti-HBs, it is an antibody for this antibody of hepatitis surface antibody. Here it will help us in knowing any previous infection. If at all patient had suffered from hepatitis caused because of this HBV, then there will be increase in anti-HBs. Then we also have anti-HBC AG, which is nothing but core antibody for the core antigen of this hepatitis B virus. It will help us in identifying any acute hepatitis B infections. Next we have anti-HBE. This is helpful for knowing any active replication of virus within the liver. Next we have for chronic HBV infections, patient can be tested for HBs AG and anti-HBC. PCR, that is polymerase chain reaction, is one of the gold standard tests which can be helpful in knowing the replication. and especially in HPV DNA within the blood. Then we also have for hepatitis C, PCR test will be helpful, and antibody for this single viral antigen, that is C100, can be tested for. Then for hepatitis D and E, anti-HDV and anti-HEF, that is for hepatitis E anti-HEV, and for hepatitis D anti-HDV can be tested within the blood. So this image shows a pathology, histopathology slide where ground glass hepatocytes are seen in chronic hepatitis B infection. This ground glass hepatocytes is one of the pathognomic feature for this chronic hepatitis B infection. Here in other picture we can see there is fatty change, cell necrosis and Mallory bodies in case of alcoholic hepatitis. This alcoholic hepatitis, that is patient who is on chronic alcoholic user. Further change, the initial symptom in this will be fatty liver change, which further progresses to fibrosis and then to cirrhosis. In the process of this change, initially patient can show many fatty deposition, much of the fatty deposition within the liver, and this histopathological slide shows us fatty change, cell necrosis and Mallory bodies within. Coming to the management. So how can we manage this hepatitis? First thing is abstinence for alcoholic hepatitis. We have to advise the patient strictly that he cannot use alcohol or he should not use alcohol. If at all, we have to reduce this alcohol-induced hepatitis. Nutritional support is very important for this patient, and corticosteroids, propylthiouracil, colchicine, a few other medications which will help in reducing hepatitis. If patient is having severe vomitings, IV fluids have to be administered to reduce the loss of fluid content and to maintain the water electrolyte balance within the blood. And interferon therapy is one of the newer therapies where biologic drugs are being used to reduce this hepatitis. And in case of viral hepatitis, whenever patient is known to have viral hepatitis, surgeries have to be postponed to reduce the post-operative liver failure risk. And in case of acute liver failure, in case of acute hepatitis where there will be massive necrosis leading to acute liver failure, in those cases liver transplantation might be necessary. And other preventive vaccinations are present, preventive measures to prevent this hepatitis. Usually dentists and oral any healthcare workers are more prone to this hepatitis because through needle stick injury also or through direct contact with the blood, in case of any injury is present or any abrasion is present to the healthcare worker, and if the patient's blood is being touched, in those cases also there will be transmission of this virus. So in such conditions what we have to do is preventive measures have to be taken. So there are certain vaccines that are available to prevent the hepatitis. Few of these vaccines include Havrix for hepatitis A and Engerix for hepatitis B. These vaccinations can help in preventing the spread of hepatitis. Thank you.